The last thing we'll talk about in this chapter is renal failure. So a lot of the disorders that we talked about earlier could potentially result in either acute or chronic renal failure. This is a problem because it's a very important system in our body. So acute renal failure can be caused by acute bilateral kidney diseases, severe prolonged circulatory shock or heart failure, nephrotoxins such as drugs, chemicals, or toxins, or occasionally mechanical obstruction like stones, blood clots, tumors, which block urine flow beyond the kidneys. With acute renal failure, there's usually sudden onset. Blood tests show elevated BUN and creatinine levels, metabolic acidosis, and hyperkalemia. The treatment is to identify and remove or treat the primary problem. So you want to do that as soon as possible to minimize risk of necrosis and permanent kidney damage. It's also treated with dialysis to normalize the body fluids and maintain homeostasis. And the dialysis is continued until the primary problem is treated and the kidney is restored. So nephrotoxins can cause renal failure. Ischemia can cause renal failure. Pyelonephritis, which is inflammation. Chronic renal failure is gradual and it's irreversible. So acute renal failure is potentially reversible, but chronic renal failure is irreversible destruction of the kidneys over a long period of time. And it's usually asymptomatic in the early stages. It can result from chronic kidney disease, congenital polycystic kidney disease, systemic disorders, or low-level exposure to nephrotoxins over sustained periods of time. So you end up with decreased renal reserve. So there's a decrease in the glomerular filtration rate. There's higher than normal serum creatinine levels and no apparent clinical symptoms. So you have some signs that you can detect, but no clinical symptoms. The next stage is considered renal insufficiency, where the glomerular filtration rate is decreased to about 20% of normal, and there's significant retention of nitrogen wastes. There's excretion of large volumes of dilute urine and decreased erythropoiesis and elevated blood pressure. End-stage renal failure is the final stage. They say there's negligible glomerular filtration rate, so very low function. Fluid and electrolytes and wastes are retained in the body. Azotemia, which are abnormally high levels of nitrogen containing compounds in the blood. Anemia and acidosis. It's considered the 3 A's of chronic renal failure. Azotemia, anemia, and acidosis. All body systems are affected because the urinary system affects all other body systems. Marked oliguria, which is decrease in urinary output, or anuria, which is cessation of urinary output. The person has to have regular dialysis or kidney transplantation in order to stay alive. So when they look at chronic renal failure, they're doing it as number of nephrons and the how much function there is, and then how much the kidneys are affected. So it happens over time, and it's chronic. So the early signs could be initially increased urinary output, anorexia, nausea, anemia, fatigue, unintended weight loss, exercise intolerance. All of those things could be symptoms of other things too. So sometimes early signs can be missed. Bone marrow depression and impaired cell function caused by increased waste and altered blood chemistry, and elevated blood pressure. After complete renal failure, you get oliguria, which is decrease in the output of urine. You get dry, pruritic, which is itchy, hyperpigmented skin that bruises easily, peripheral neuropathy, impotence in men, and menstrual irregularities in women, encephalopathy. These are all bad things, right? Congestive heart failure and dysrhythmias, failure to activate vitamin D, possible uremic frost on the skin, and systemic infections. So you're in the hospital at this point. The diagnostic tests, they test for anemia, they test for acidosis, they test for azotemia, because those are the key indicators. All body systems are affected. It's difficult to maintain our fluid, electrolyte, and acid-base homeostasis. We know how important those are. Drugs are needed to stimulate erythropoiesis. Drugs are needed to treat cardiovascular problems. The intake of fluid, electrolytes, and proteins have to be restricted. And dialysis needs to be done until transplantation is available. So chronic renal failure is very serious at this point. So this is a little chart from the book that compares chronic and acute renal failure. The reason they call it end-stage renal failure is because unless you get a kidney transplant, it is the end of your life. So as far as PT guidelines go, the primary physical therapy goals in this patient population are similar to those of other patients in the acute care setting. Because when you're into chronic renal failure, you're pretty much in the acute care setting. The goals are to optimize safe functional mobility, to maximize activity tolerance and endurance, and to prevent postoperative and pulmonary complications. So that's what we're trying to do with our PT treatments. So in chronic renal failure, the inability to regulate cellular waste products, to regulate blood volume and electrolyte levels can result in mental status changes because of the buildup of ammonia, BUN, creatinine, or a combination of those. If this happens, then the therapist might have to modify or defer physical therapy, particularly educational activities, because the patient is not up to it at this point. If it requires concentration on their part. They talk about disruption of excitable tissues such as peripheral nerves and skeletal, cardiac, and smooth muscles from altered level of electrolytes. If that occurs, then you have to reduce exercise intensity during muscle strengthening activities. Because if all of those things aren't working, it's pretty hard to perform muscle strengthening activities. And if peripheral neuropathy results in sensory deficits, then you have to take appropriate precautions with the use of modalities. Because if they don't have the sensory component, they're not going to be able to give you good feedback. And you have to educate the patient on protective mechanisms to avoid skin breakdown, the patient and their caregivers. Peripheral or pulmonary edema from inability to excrete excess body fluids can result in shortness of breath with activities, and if you position them in a recumbent position. Peripheral edema can result in range of motion limitations and skin breakdown. So very serious effects for these patients. Fluid and electrolyte imbalance can also alter the hemodynamic responses to activity, so you have to be really careful to monitor their vital signs and their symptoms during treatment, and terminate treatment if you have any bad effects. So blood pressure regulation can be altered because of the body fluid and the renin-angiotensin system. Activity tolerance can be reduced by all the factors we mentioned, as well as from anemia that can result from the decreased erythropoietin secretion from the kidneys. A lot of times when patients are receiving dialysis, they will have various levels of fatigue. So different patients are going to be different. Some of them are more fatigued before a dialysis session because of the buildup of waste in their body, but other people are more fatigued after a dialysis session. So a lot of times they're happening 3 times a week, but they might be on a different schedule depending on the patient's individual situation. So Patients with urinary dysfunction can have referred pain. They can have that flank pain. And PTs and PTAs can play a role in differentiating the source of a patient's back pain, as well as providing symptomatic management for the referred pain. Patients who have had surgical procedures with abdominal incisions with urinary system, they're definitely going to have abdominal incisions. They're less likely to perform deep breathing and coughing because of incisional pain. So working with them on positioning, instructing on incisional splinting during deep breathing, and coughing, along with early mobilization, can help prevent the development of pulmonary complications. So really important education pieces with these people post-surgically.